to decrease your testosterone production. And then now there's immunotherapy, there's chemotherapy. Chemotherapy, actually, before, which used to be the only treatment for cancer that had spread outside the prostate gland, is being used less and less, right? We don't have to kill your, give you chemotherapy to injure everything, right? We can use immunotherapy, which is directed towards the prostate cancer. Use hormonal therapy, which is directed toward prostate cancer cells without injuring your other cells. So when we talk about hormonal therapy, again, testosterone stimulates cancer cells. We can decrease the testosterone that's made by your testicles and keep it from getting to the prostate. So one thing we do is we usually will give a medication to decrease the testicular production of testosterone, and then we can use other medications that block any testosterone that's produced from getting to the cell. So those work out quite well. We have an immunotherapy that's available now. It's called Provenge, and that's where we take your blood and sensitize it to prostate cancer cells and give it back to you, and we allow your cells to fight the prostate cancer for you. And that's something that we're doing early and earlier on in the disease, because we find that men who are still robust and strong and have active immune systems, their immunotherapy can work quite well for them. And then the sort of next slide talks about, how do we go about the treatment of prostate cancer? And it's changed a little bit over time. But, first we start with local therapy, radiation, prostatectomy, what have you. Then we do that hormonal therapy, and that would be something to decrease testosterone production from the testicles. Then there's second line hormonal therapy that blocks testosterone from getting to the cells. Immunotherapy, chemotherapy. So again, when we talk about prostate cancer, there is just a whole new world, multiple treatments that are out there. And I will say that part of the reason why this is and why we all benefit as men is that a lot of men are being diagnosed with this disease, and men want to live. They want to get the best treatment possible with the least side effects. So treatment is improving. So when we talk about side effects of treatment, again, urinary incontinence is the one I tell people I would be most concerned about. ED, we can fix that. Infertility, if you're particularly young and you have to have your prostate removed and you're concerned about having more children, I recommend men bank sperm, and that works out quite well. Hormonal therapy, radiation. So all these things are possible side effects. But again, first and foremost, you have to decide, am I going to live with the side effects or am I going to die from prostate cancer? So they can all be treated and managed. So when we talk about prostate cancer also is that, let's say, you're a guy, you're in your 60s or 70s, you've been working with your urologist for the past 20 years, and he's also in his 60s and 70s, and he may not be sort of up on some of the newer treatments. You may have to ask him, sort of what's out there, doctor. I've heard about these genetic tests. I've heard about something called the 4K score. So I'll go through these a little bit just to kind of bring them up so you can put them in your head if you're ever confronted with this disease. Obviously, PSA is what we use. I use a lot of this test called the 4K score. And this is a test where if you have an elevated PSA, it'll give me your risk for clinically significant prostate cancer. And if you have very low risk for clinically significant prostate cancer, maybe we can forego your biopsy. But it also helps me confirm my suspicion that you need a biopsy. And then if the biopsy is positive, sometimes we do a confirmed MDX where we look for what's called the halo effect, because there's a possibility I did your biopsy and I missed the cancer. And this test helps me to feel comfortable. Do I need to do a repeat biopsy? We do MRI now quite routinely. So I have some patients who come in and say, well, Dr. Anglade, my PSA is elevated. Can I have an MRI before you recommend a biopsy? And in general, if your insurance will cover a prostate MRI, I have no problem recommending it. Many insurers will not cover it without a negative biopsy previously or without a biopsy previously, but if they cover it, I'll order it. But I will be frank and say that if a gentleman has an elevated PSA, he falls into a risk group where I need tissue, an MRI, and even when the MRI is done, the radiologist will say an MRI does not supplant nor replace a biopsy. I'll say, oh, look, I'll get the MRI. It may help me direct where I need the biopsy, but you still need a biopsy. No, so I will not let an MRI determine whether you need a biopsy or not, at least for the initial biopsy. If your biopsy is positive for cancer, I use a test called the Oncotype DX, and I found it to be very helpful in my practice. That's down here. Prolaris is very similar, but these are tests that will help me decide whether or not a patient is reasonable for active surveillance. Because what's done in these tests, the prostate cancer cells are examined, their DNA is analyzed, and sometimes you may have a cancer that looks actually pretty benign, but the DNA of the tumor shows it to be fairly aggressive. So that may help me decide whether or not I think someone would benefit from active surveillance versus a more aggressive treatment. So Prolaris, Decipher, ARV7, and these are newer tests, genetic-based tests that help us have an understanding of is more likely or less likely after your prostatectomy will you have a recurrence. You know, how closely do I need to monitor you? How quickly do I have to recommend an additional treatment if I see that the PSA doesn't go down to zero? One thing I should mention too is that after treatment for prostate cancer, particularly after a prostatectomy, we expect your PSA to go to zero, right? Or as close to zero as possible and stay there. So a successful prostate cancer treatment is one that takes your PSA from whatever it may have been, 6 or 7 to zero, right? And if it's zero and it stays at zero, you're good to go. We usually say that a PSA that stays undetectable for 5 years is considered cured. Now, some people say, well, Dr. Anglade, you know, my PSA has been 5 years, it's been zero. Do I still need to get a PSA check? Yes, annually, you still do, because cancer can come back. Even though we don't expect it to, it can come back. I'd say 95% of men who have a PSA of zero at 5 years, they will never have to worry about it again, but there's still that 3 to 5% which may have a recurrence. Dr. Anglade, I had my prostate out. Why does my urologist still want to stick a finger in my backside? Yes, you still have to have that, maybe not annually, but every couple of years, just to be sure there's no recurrence, there's no abnormalities that can be palpated there. So I don't think there's any time when any of us get past that digital rectal exam. You know, you can make the argument when a guy gets to be 70, 80, 90 years old, does he still need it? Maybe, maybe not, but if just the inconvenience of have someone feel my prostate, I think it's worthwhile to get the test done. Another test that I'll mention just briefly here is an Axeman scan, which I use a lot in my practice. For a long time, the imaging that was done for prostate cancer was just what we call a bone scan and a CT scan. You have a CT scan with contrast and a bone scan. But you know, women who had breast cancer would get a PET CT scan. You'd have people who had colon cancer would get a PET scan. And they were more sensitive, but prostate cancer was not picked up by PET scan. Now there's what's called an Axeman scan that uses a new marker that can be picked up and is extremely sensitive for prostate cancer. So again, if you have a urologist who's maybe, you know, kind of older, isn't informed of these treatments, they might not know to order those tests. So sometimes it's important to find somebody who's more in tune with the newer treatments. So I'm getting close to the end here, but when we talk about cancer mortalities, again, when we talk about prostate cancer, regardless of whether you're black, poor, black, rich, white, poor, white, rich, you're seeing that the mortality rates are decreasing, which is excellent for everybody. And for all cancers, it seems like most mortality rates are in the decline because we are getting better for treating prostate cancer for cancers in general. You know, I was watching the evening news this evening, and now that political ads, except here in Georgia, are starting to die down, you see more ads about cancer drugs. So we've got new drugs that are good, that are effective, and have low side effects. So most people say, well, Dr. Anglade, no, I appreciate all of this, and I feel healthy, and I'm trying to adopt a healthier diet because I don't want to be treated for these diseases. And one of the things I mention most frequently is the same stuff we mentioned for any cancer. Physical activity, eat a healthy diet, decrease animal protein, decrease tobacco. Oh, first of all, decrease tobacco completely, decrease alcohol. Specifically for prostate, what's good is lycopene. and that's found highly in tomatoes. Some people say they don't like to eat tomatoes because it's a quote unquote nightshade vegetable with lecithin, which is bad for the gut. If that's an issue that you have, you can get lycopene in supplement form. So I think those are the things you can do to help decrease your risk for developing prostate cancer. And I do think that there are a lot of men in our community who have dealt with this disease, and it's always good to ask them, sort of what their experience has been. So generally, I speak to my patients and I tell them, look, if I recommend a prostatectomy or radiation, you should speak to friends you've had, family members, and get their opinion. Because a lot of times they're quite candid. They may say, well, geez, I wish I had the prostate out because I'm dealing with recurrence. My prostate's been radiated, and the doctor says I can't have it out now. So now I'm dealing with all these hormone treatments, right? Whereas a guy may say, look, I have my prostate out, now I'm wearing a diaper and it stinks. So, but if you have that guy's wearing a diaper, please send them to me because we have treatments for that. So in conclusion, definitely, I cannot stress enough, get your PSA drawn as much as you want to, at least once a year. If you're at work and they're doing a PSA drive, it never hurts to get it drawn more than once. Request a digital rectal exam. I'd say at least, ideally once a year, but if your primary care is resistant, every other year or so. Just recommend, look, I'd feel comfortable with an examination. If you don't feel comfortable doing that, would you refer me to a urologist so I can get screened? I'm a man of color, and I feel that we're at higher risk. Can you recommend that? And if you are diagnosed with cancer, prostate cancer nowadays is really not a death sentence. It's not even a sentence of impotence, decreased sexual functioning, incontinence. We've got very good ways to treat it. So knowledge is king. Find a urologist that you trust who can help you out and help you make decisions as to how to proceed. So with that being said, I've spoken way too much. Again, I'd like to open the floor. I think that Mr. Robinson has some questions. Brother Robinson has some questions for me. And if you have any questions, urologically inclined, BPH, ED, I'm here for you, and I'd love to entertain them. Thank you so much for your attention. It's been my honor and privilege to speak for the Lake County Alphas this evening. And
we thank
06.
06 to you. We thank you because this is a heavy topic, but it's an important topic. I'm going to ask a favor. Can you stop sharing your screen so we can see everybody on the Zoom? And then if people have questions, again, please, you can chat me directly. My name is Rodney Robinson, or it's under Lake County Alphas in the chat box here. You can also send a chat to Dr. Anglade. But again, we have about 10 minutes of questions, Q&A, and I just want to thank you all for signing up, for registering. I mentioned, Dr. Anglade, that this is beyond Alpha. This is beyond Lake County. This is certainly all of our relatives. These are the people we love. These are the community members that we have. These are men and women who care for their men that need to know about this important topic. Yes, it's a heavy topic, but we also hope that you have good data points that you can use for your personal health report card when you go talk to your primary care physician and get your annual physical. Typically, you don't meet a urologist for the first time. You meet your primary care physician, but now you know that you can have a partnership with a urologist as well. Again, I want to thank Dr. Anglade for taking us through this detail, through these topics. We do have some questions. I see some questions are popping in now. And I just want to thank everybody again for signing up, because we wanted to advertise this out to the entire Lake County community. We've had folks, my father's on this call right now from Florida. My brother-in-law is on this call from Florida, and as well as members from the chapter of Kappa Chi Lambda. So we do appreciate you taking the time and being part of this session tonight. Very important. And we will, because I have all your email addresses, send you a link to this presentation. Please share this presentation with your father, with your uncle, with your cousin Pookie, with everybody that you care for, because the more we know, the longer we live. And I think that's the key. It's not a death sentence, as Dr. Anglade said. We all want to live longer. It is treatable. We can catch it. And I go back to that one stat, that 1 in 6 of all Black men will develop prostate cancer, period. Hard stop. So the more we know, the longer we're going to live. So I'm going to jump in a few questions. Again, I thank you all for sending us some questions in advance when you registered. I'll ask a few. I'll go back to the chat. We'll see what's there. And Dr. Anglade, thank you again for making the time this evening. So here's a question for you. One question is, does a digital rectal exam substitute for getting a PSA test, or must they be used together as a clinical preventative package? I think you touched on that, but if you can just put a fine point on that.
Yeah, definitely. For the digital rectal exam, honestly, is probably not as important getting the PSA. They work together. If I feel something on a digital rectal exam, regardless of what the PSA is, it needs to be biopsied. I've diagnosed men with normal PSAs based on the digital rectal exam, but they go together. Now, we all may have heard or been informed that recently, it's in the past 10 years, there was a big discussion as to whether or not even doing prostate cancer screening was necessary. As a urologist, I think it's highly important that we get that done. I think it did a disservice to men in general, but men of color in particular. I have a question here that somebody sent to me. You know, when should a man start getting screened? African American men in general, I'd say 45, and have a first degree relative at age 40. Just because I'm a urologist, I started doing mine at age 40. I don't think that any primary care physician would bristle at your requesting, look, I'm 40 years old, I'd like to get my PSA checked. They may say you don't need a digital rectal exam, and that's probably reasonable, but at least you can start getting that PSA data. Because the longer train of data, the more data points we have regarding your PSA, the more important it is. One thing I will also mention is that some practitioners will say, well, your PSA was less than 0.5 and you're 40 years of age, you don't need it done this year. That is, again, very reasonable. But in that case, you'd probably do it every other year. If you have a very low PSA on initial testing, do you have to have it done every year? Probably not. But again, if you want to be particularly sensitive to your prostate cancer diagnosis and risk, I suggest a digital rectal exam and a PSA test annually. So,
appreciate that.
Again, I'm going to recommend what I recommend to myself and my friends: get your prostate checked once a year, get your PSA done once a year.
Okay, I'm going to go through some live questions here. So, are there any relations in a father who successfully recovered from prostate cancer and his son, who might be late 50s, being told his prostate is now enlarged? Exams have been routine and good, but if the prostate gets enlarged, how much should that person be concerned? And one quick point I know Dr. Anglade mentioned to me a while back is that if you live to be 90 or 100, your prostate will likely be the size of a grapefruit. It's going to keep growing as you get older. So again, the question is an enlarged prostate with a family history of prostate cancer an extra reason for concern?
No, an enlarged prostate, again, most of us our prostates will grow as we get older. I should say not most of us, all of us. As we get older, our prostate's going to get bigger. Maybe you get up at night to pee a little bit more frequently, your urine stream is slow. So that's going to happen, okay? If you have a father who has been diagnosed with prostate cancer, again, you're going to do what any of us would, and that's get your PSA checked and your prostate checked annually. If we find that the PSA is rising or it's fluctuating a little bit, I may make that recommendation every 6 months. If the PSA is elevated and then you have a negative biopsy, I generally make that recommendation every 6 months. But one thing I would say is if, let's say, you have a father who had prostate cancer and you're being told your prostate is enlarged by your primary care physician, I would say, would you mind referring me to a urologist? I think I'd like to see somebody who can kind of look at that a little bit more closely. And I don't think most primary care physicians would have a problem making that recommendation. And then the urologist could take over the management and proceed from there. Okay.
Question for you about systemic racism issues with medical care. Historically, Black Americans, we've had a truth in mistrusting our doctors, or let's say take a vaccine for this, or you don't need the surgery for that. What do you recommend that we insist from our doctors if we're 45 and over and they don't recommend a digital exam or the PSA exam. Certainly we'll have to insist on that, but are there other things we can do as Black men to make sure that we're getting the primary treatment if our doctor, of course, is not African American?
You know, it's a it's a very real thing. You know, I'm actually looking at my phone now because I'm on a listserv chat, on a WhatsApp chat with Black urologists, and I was trying to see if I could find it, but we just had a recent statistic where African Americans in the field of urology are highly underrepresented, right? And we're trying to encourage more medical students to try to go into urology, although getting urology is a fairly competitive process. Um, I think that if you have a primary care physician who is resistant to referring you to a urologist, it may be worthwhile to seek a urologist outside of their referral, and see if you can make an appointment with urologists in general. I do think you can be a little insistent upon the digital rectal exam, and you can say, well, look, I understand it may be a little uncomfortable for you. Do you know anybody who wouldn't mind doing that for me? Because I think it's important. So I mean, I think those are things you could request. I will say that here in Atlanta, we've probably got more Black urologists per capita than any city in the country. So we are kind of rare to find in many parts of the country. So, I know in the Chicago area, there are some urologists that are out there. So again, I think that it's incumbent upon us to stand up for our health and say, look, I'd feel more comfortable with an exam. If you don't feel comfortable doing the exam, would you mind referring me to urologists who would do that for me? Great. And I think that's well within our rights.
Great. We'll do a few more. Let's open it up because it's just us talking. We might as well ask the real questions if we can. Does anybody have any direct questions they'd like to ask Dr. Anglade?
All right. Well, I'm going to step in with something else that broadens this topic. We talk about BPH, okay? Because that's a topic that I think I should mention. So a lot of guys think, okay, doc, I'm getting up, I'm peeing at night a little bit too much. I can't sit through a movie. I got to pee. I have, my stream is slow, and they're afraid to bring that up because they think, okay, I'm going to tell them they have cancer. And in many instances, and in the vast majority of instances, that's not the case. You don't have cancer, you just have an enlarging prostate. And the thing I would say about that, there are very good treatments now for enlarging prostate. Medications are quite good. There are generic medications that are inexpensive that can help with treat enlarging prostate. We've also got some very good minimally invasive procedures where we can open up the prostate to allow for better urine flow and keep from getting up at night. There are better surgeries now for prostate and enlarging prostate. So that is probably more common for us in enlarging prostate than dealing with the cancer. So don't be afraid of that.
A related question to that is, we might hear on the radio, like, take these supplements to reduce your prostate size, this, that, and the other.
Mm-hmm.
Is that accurate? Supplements good? Is the hype real for maintaining a healthy prostate and preventing cancer?
Well, there's probably one or two supplements. Well, one supplement that I think has some legs, and that's what's called saw palmetto, okay, because it has what's called beta-cytosterol in it, and that's the one that they advertise as super beta prostate. That's the one I think is most commonly advertised. I don't sell it, whatever, so I'm not, an advocate of it per se, but I found that one to be helpful for a lot of my patients. They say that it does help. Now, pharmaceuticals that are good are, the Flomax. A lot of guys have on something called tamsulosin, which helps to relax the prostate. Some men don't like taking tamsulosin because although it helps them to urinate, it may affect the way they ejaculate. There's one called uroxetrol that doesn't have that much of a side effect. There is daily dose Cialis, which helps with both erectile function and with urinary frequency. So that's a medication I use quite commonly in my practice. There's a procedure called Urolift, where you can put clips into the prostate to spread it. Doesn't affect you sexually, doesn't require a major operation. So a bunch of things we can do to help a man as he gets older and deal with an enlarged prostate. So the one thing I would suggest is that if, let's say, you go into a urologist and say, look, my prostate's enlarged, and all they have to offer you is TERP or a roto-rooter, sort of the way I call it, you know, it resonates, then you need to find another urologist because we've got so many different treatments out there that can help and really cause minimal, if any, side effects.
Yeah, and again, that Charles, send the deck out, that chart at the end with the other options that didn't exist probably 5-10 years ago. Know that and learn that. Last question for you, Dr. Anglade, because we talked about this in another conference we had last month. The question is there a way to prevent prostate cancer altogether? Because, you know, a lot of us think like, okay, we're younger, we're not there yet. The statistics are bad, but how can I just bob and weave and avoid it? And I say that because when we asked the question last month, women might say if they had breast cancer, I'll get a mastectomy and help prevent the chances of me getting breast cancer because I have a family history of it. I want you to talk just a bit about how it's not that easy for prostate cancer.
Yeah, I mean, you know, the breast cancer, obviously doing a mastectomy is sort of easy because the breast, after you breastfed or had children, they really serve no purpose. I shouldn't say it like that, but they really don't. I mean, you know, you can have your breast removed, have implants, have reconstructive surgery, but they really serve no functional purpose. The prostate in a man over our lifetime does actually have a functional purpose to a certain degree. The prostate produces the majority of our seminal fluid, so that's what helps to nourish our sperm. The prostate does provide some continence. It does help us to hold our urine. So taking out a prostate is not something we take lightly. Again, removing breast off the top of the chest is fairly easy to do. Removing prostate deep in your pelvis can cause some significant side effects. So we don't generally remove a prostate unless it is truly cancerous, as you have a diagnosis of cancer. So is there anything we can do preventative? Again, it's the same stuff we talk about with any sort of cancer. Diet, exercise, you know, decreasing tobacco use, alcohol, those kind of things. And they'll help. You know, my feeling is that you know, maybe taking a lycopene sort of vitamin, tomatoes, is helpful. So those are the kind of things I do in general. But as far as our ability to fight it all together, you know, I think unfortunately there's no real cure or answer for that at this point.
And I tell you, everyone, let's fight it with knowledge. Now that we know more, let's know it for ourselves. Let's know it for our families, know it for our communities. With that, we're at time, and this is, again, our inaugural Alpha Conversation, a focus on prostate cancer, brought to you by the Lake County Alphas. I just want to thank you again, Dr. Anglade, because even though you're in a luxury spot in Atlanta, I know you have about 6 Black urologists at Georgia Urology, and they're all alphas too, which is pretty incredible. You know, we don't all have that luxury here in other areas of the country. So I will email out a link to the deck for folks. I'm going to send you Ron's, Dr. Anglade's business email. If you have questions, he can hopefully give you some good referrals. And this is very valuable time. Again, it's heavy information, but it's important information because we all want to live longer and do what's best for ourselves and our families. So thank you very much. We appreciate your time.
Gentlemen, thank you very much. I appreciate the opportunity to speak to you all. Have a good night. And thank you very much for the opportunity. It's greatly appreciated.
Thanks everyone for tuning in. And again, we have your email so that at our next Alpha Conversation, we'll make sure we keep you on the list for that. Thank you and have a good night.